those guys are interesting in the second because this rookie Terrell had a phenomenal preseason. Right. Really ran to a long guy from cut himself. He just came back this week. He played with the Steelers in minor league and he hit like 500. So they wanted to know he's going to get some playing. So now he's going to really need to straight here last night for a first time.
What they need, boy, I don't think I've seen, I can't remember the last time. I just can't remember. Maybe it never happened.
Yeah,
all right, okay.
Yeah,
right, okay. Yep. I actually had tickets for that, but that wasn't one of the kids there. I couldn't go. I was I'm not sure I understand what I'm saying. No more. Leave the way.
We're at 901.
But they will come in.
And the disclosure slides, you don't really
This is the fourth time they're saying the same thing. Yesterday they saw I mean, it's simply follow-up. I presented a case, and I always do each year of an older person. Actually, I showed a picture of Alice's mother, but years ago. But
not the one that's topless, right?
No, not the top.
So that would be a little weird.
So I told him about this patient I had, a 43-year-old in the hospital with ATN, and I told him he was pregnant. He was trying to decide what to do. I'm going to give him the follow-up during this.
Do you know how to do the lights here? I assume it's this.
That sound. That sound. I do not know. I just leave them on. I haven't touched the lights.
All right, let's get it going here. Good morning.
What you may want to do is...
Good morning.
You want to leave this here. And just, then just leave this up here for the switches. You just hook it on here. It's this long enough. You won't go wandering.
Okay.
Yeah.
All right. Do I control the lights here? Sorry. Yeah. Create a certain ambiance. All right. Good morning. I am Glenn Markowitz. I have the pleasure of lecturing to you today and working together with Dr. Appel. These are the conflicts of interest. I must say that sadly I have no conflicts of interest. I would like to have a few more. In terms of the objectives for today, this is about as repetitious as it gets. I basically wrote the same thing 3 times. To gain a basic understanding of the clinical presentation, pathologic findings, and etiologies of ATN, which is acute tubular necrosis, AIN, which is acute interstitial nephritis, and acute and chronic pyelonephritis. And if you don't walk out of here today knowing what those 3 things are, we didn't do our job. So let's just start in sort of broad terms in terms of mechanisms of tubulointerstitial disease. Now, one thing you should know by now is that when you look at a kidney under a microscope, you see 4 things. You see glomeruli, you see tubules, you see interstitium, and you see blood vessels. From a physiologic standpoint, you kind of learn more about the tubules than anything. From a disease standpoint, you tend to get a lot of information taught to you about glomerular disease and a lot less on tubulointerstitial. So we're going to do all the tubulointerstitial diseases in the next 1 hour. And basically what damages tubules is 2 different pathways. One, where there's ischemic or toxic injury, which means the tubule either is getting inadequate blood flow or has a toxic exposure, and therefore will become damaged in a way that does not involve inflammation. So this is the non-inflammatory damage pathway. And then the second general category is inflammatory injury, which we can call broadly tubulointerstitial nephritis. And realize there we're dealing with, it could be inflammation from infection, It could be an allergic or drug-induced reaction. It could even be a systemic disease that also involves the kidney, where you get inflammation systemically, but also within the kidney. So again, I make the point, just to repeat myself, when you look at a kidney, if there's one thing I think is critical, you say to yourself, I see glomeruli, I see tubules, I see blood vessels, and I see the interstitium, the space in between. And the point I want to make on that, to further emphasize it, when I see kidney biopsies and I see people in renal failure, I say, is it a glomerular, tubular, interstitial, or vascular disease? And so we're going to cover today the tubular and interstitial causes of renal failure. So this is what a proximal tubule looks like up close. And as you no doubt recall, there is this brush border that really increases the surface area. And when we look here on scanning EM, you're in the tubular lumen right now looking down at a tubule. This is a single tubular epithelial cell. And this intense brush border increases the surface area by about 600 times in terms of the ability to reabsorb at that surface. So it's a critical part of the proximal tubule. It's also something that goes pretty quickly when the tubule's damaged. So a really damaged tubule will lose that brush border and then over time has to try to reconstitute it. This is an EM, sort of a regular transmission EM, and here we're just looking at one tubular epithelial cell. Here's the nucleus, here's the nucleolus. Here's the brush border that you can see by EM. Down on this end would be the tubular basement membrane, or the interstitial side. But what I want to point out to you is, look at all these structures, and these are mitochondria. And tubular epithelial cells, particularly proximal tubular epithelial cells, have among the highest content of mitochondria of any cell in the body, and that's because they have an intense energy requirements for the immense amount of reabsorption that is occurring and is energy dependent in the proximal tubule. So with that as a background, I'm going to turn this over to Dr. Appel, and we're going to go back and forth all day, or all hour. Sorry.
Not if he takes the microphone.
Okay. Thank you, Glenn. So the first case is a 58-year-old white male with a history of alcohol abuse. But we know this person has normal renal function because he came to the emergency department about 2 months ago. He came in for something minor, a fall or something, and at that time we know his creatinine and his BUN were entirely normal. He now is admitted to the hospital in a stuporous condition. He's been found by his friend in his room. He's totally unarousable. His friend states that they had been drinking for 3 days, and when he called to find his drinking buddy to go out again, nothing happened. The guy didn't answer the phone. He went over there, and he found his friend passed out with a bottle of Jack Daniels lying next to him. Okay, this sounds like a Law and Order beginning or something. Anyway, he comes in. His blood pressure is 100/60. His pulse is 110. He is febrile. His heart is normal. He has some rales at the right base of his lungs. His abdomen is benign. Extremities show swelling and tenderness of both right and left legs below the knee. So he's got tender right and left calves. His BUN is 48. His creatinine is 6.2. We know this person has a problem here. I mean, his creatinine is way up there. If you talk about AKI, acute kidney injury, creatinine elevated, that's it. Okay? His white count is elevated at 15,000 with an increased shift to the left in polys. His chest x-ray has a right lower lobe infiltrate, likely an aspiration pneumonia. You look at his urinalysis, only trace protein, 4+ heme. It's positive. Remember the dipstick, we check for protein, mostly albumin is what picks up, and you can check for blood and sugar and a whole bunch of other things. There's no red cells and no white cells. So think about that. We've got 4+ heme positive, but we have no red cells in it at all. The patient's hydrated with a liter of saline and his blood pressure comes up. He's given a dose of an aminoglycoside antibiotic, gentamicin. He's given a dose of ampicillin here to treat presumed infection. Over the next 2 days, he makes very little urine, and his creatinine continues to rise up to 8.4. We look at his urine sediment. We see these muddy brown granular casts, the so-called ATN casts, okay? But you can see you can't make out cells in them. They're not white cells, red cells. They're these granular casts. So the first question is, should a kidney biopsy be done? How many people, we can raise your hand, but everybody has to vote. How many people think a kidney biopsy should be done? How many people think a kidney biopsy should not be done? That's good. Well, this is the only time I will ever stand in front of you with a pathologist and say a kidney biopsy shouldn't be done. Because 99% of the time when you're with a pathologist at a conference, it's a biopsy conference, and the answer is a biopsy is always done. But you're absolutely right, because again, all the etiologies here are things you'll see that really don't need a biopsy right away. On the other hand, as we get through this, you'll see the next case, etc., we do need biopsies. So, is the renal failure acute or chronic? Okay, I'm not even going to ask for a show of hands. It's clearly acute. At worst, it could be subacute, but regardless, we know he had normal renal function 2 months before. How can we prove it in terms of this? So, we could do an ultrasound to show normal-sized kidneys. We could show that he's not anemic. You know, if you had chronic renal failure, you'd have small shrunken kidneys, you'd be anemic, etc. But we have the best thing. We have lab values from before. What is the most likely etiology of his renal failure? Should we take a vote on this one? Because we'll get a split here. Okay, I can guarantee you from past years. How many people think it's hypotension, low blood pressure? Okay. How many people think it's rhabdomyolysis? Okay, we got some votes. How many people think it's gentamicin? Okay, we got votes. How many people think it's leptospirosis? Okay, now I can tell you for the person who voted for leptospirosis, in your entire medical career, leptospirosis will never be the answer to anything. So you just, you know, even Dr. Garrett will not use that on a test. Okay. So we actually, he's already writing it down now. Okay, so what lab values might be helpful? The urinary sodium might be helpful, the fractional excretion of sodium, the specific gravity, the osmolality, all the things we talked about in distinguishing prerenal azotemia from ATN. Remember, if we look at acute renal failure, which again most people now call acute kidney injury, that we have prerenal, perfusion problems of the kidney, postrenal obstruction, okay, and then we have intrinsic renal disease. There are only 4 things in the kidney. There are tubules, there are glomeruli, there are blood vessels, and there's a space between them. So anatomically, there are only 4 things in there, and you can have problems with each of those. We've already talked about ATN before when we talked about AKI originally in that lecture a week ago. We've already talked about acute glomerulonephritis with Vivette yesterday, that we're going to talk about acute interstitial nephritis today, and we're going to talk about vascular disease when Barry Stokes comes in about an hour. So let's see what this patient actually had.
You know, I should apologize to you all. I was a little bit late this morning. My father's hospitalized with leptospirosis, and no one could think of the diagnosis. That was a joke, don't worry. So this is what the biopsy shows, and so what we're leading up to here is that this is a case of acute tubular necrosis. And so this, of course, there's a couple inflammatory cells, but that's not the main finding here. These tubules are tremendously damaged. You do not see any brush border on these tubules at all. You see many sloughed, necrotic tubular epithelial cells, you know, in the lumen, and these will be passing along in the urine. You see an attempt at a mitotic figure here to try to repair these tubules. You see a tubular epithelial cell nucleus here, and the next nucleus is not until all the way over here because these cells have all sloughed off, and you just see tremendously damaged tubules. And this is what ATN looks like by EM. And so this is sort of flipped upside down because the tubular basement membrane is here, but here this would be the luminal side, and you can see there's complete loss of this brush border. You can see these mitochondria are very swollen here. You can see that there's shedding. There's actually mitochondria floating out here in the tubular lumen. These have been shed organelles of severely damaged cells. You can even see that neighboring cells have lost their intracellular contacts, and so the filtrate goes right up against the tubular basement membrane. But this is what ATN can look like at the ultrastructural level. This is a light microscopic appearance of a particular case of ATN, and this is a bit of a theme I'm going to focus on a little bit, which is that with toxic ATN, I would say there's sort of like a look of ATN. and it's just tubular damage. But sometimes you get a particular cause of ATN where you can actually say, oh, that looks like an ATN due to X. And this is one of those examples because this is a case that has really a ton of these really big, sort of muddy brown, but particularly dark casts, browner than other casts that you see. And this is actually a patient who has myoglobinuric ATN. And so when you have severe damage to muscle, and there's sort of muscle breakdown with massive release of myoglobin, the myoglobin will precipitate as these brown casts in the tubules. And that also makes a point that when you hear me say something like toxic ATN, that you're exposed to a toxin, people think of toxins from outside of the body. But if something intracellular within the body gets released in massive amounts, that too can act as a toxin. And in fact, with this myoglobinuric ATN, you even can get some brown discoloration within the medulla, more so than you would normally see grossly in a kidney. So getting to this topic of ATN, which is absolutely positively the #1 cause of renal failure. It doesn't get biopsied in most cases, but when someone comes into the hospital with a baseline normal renal function and has a creatinine of 4, your first thought is ATN until proven otherwise, and then you go through the steps to prove otherwise. So why does this happen? It happens really because there's proximal tubule is predisposed for 2 reasons, and it all makes sense. One is there's tremendously high metabolic activity, very high O2 requirements, energy requirements, and therefore it's going to be very prone to ischemic or hypoxic injury, and we call that ischemic ATN. And the second reason is that the proximal tubules have a big role in concentrating and reabsorbing the filtrate. The proximal tubule is only a short segment of that nephron, but it does about 65–70% of the reabsorption. And so therefore it's got a very high level of exposure to any toxins in the blood. And so that's toxic ATN. And so just keep that in mind, high metabolic requirements and concentrating. So ischemic ATN, which we'll start with, occurs in the setting of decreased renal blood flow or severe hypotension. So for instance, there's trauma, there's severe blood loss, there's heart failure, there's septic shock. You're just not perfusing the kidneys adequately. And the pathology here, I always find this cute. No one else finds it cute. But I always say the pathology is PNS for pale and swollen, but no one ever finds that cute. But anyway, the kidneys often look pale and swollen grossly, and what you see is tubular degenerative changes, and in time, hopefully, you'll see tubular regenerative changes, and there'll be mitotic figures, and it'll reconstitute itself. There's a high level of, let's say, a return to normal, of remission, of coming back to normal. And then the most severe changes that you'll see in ATN are really in the proximal tubules and also in the medullary thick ascending limb. So the usual phases of ATN, it says the initial 36 hours, which is dominated by the initial event. Someone comes in with an MI and major heart failure. You're really paying your closest attention to the cardiac issues, but at the same time the creatinine's going up. And then you hit this sort of point where the initial injury is set, and now you have a maintenance phase where there's sort of this slow recovery. That can take 3 weeks. It can take more than 3 weeks. During that time, you won't make a whole bunch of urine, and usually, or in many cases, you'll require dialysis to sustain you. And this really makes the point how dialysis is sort of a modern-day miracle. Because 100 years ago, if you had ATN, you would very possibly have died because you don't have that 3 weeks that you can get by without renal function and the severe electrolyte abnormalities that occur. Now you go on dialysis for 3 weeks or so, and you can really do great. And then finally, there's the last phase, which is the recovery phase. And what happens here is you don't just start urinating again, but you usually start urinating far more than normal. And the reason that's thought to be is you're back to really filtering normally, but you don't have that proximal tubular brush border fully reconstituted to reabsorb. So you filter, you can't reabsorb as well, so you make excessive amounts of urine. And you'll still have electrolyte abnormalities, but usually we say that if someone has ATN, the first sign of recovery when they're on dialysis is that they'll start urinating more. And then we'll know good things are happening. And I put in this slide 90% recovery if survived the initiating event. That's a hard number to pull. It depends on the setting. Some would say it's too high. Maybe it should be 80%, but the bottom line is recovery rate is pretty high, and there's no real therapy available to help these patients other than supportive measures. This is actually, I showed you before that horrible ATN with all that sloughed necrotic tubular epithelial cells. I said this is a really severe ATN. Well, that would be a case that was actually biopsied in the initial phase. This is the same patient that went for a repeat biopsy during the maintenance phase, and you can see you no longer have these sloughed epithelial cells, you just have this very flattened epithelium. And believe it or not, this patient had a third biopsy. This is probably 40 years ago when your biopsies didn't have to be quite as justified as now. And this patient had a third biopsy in the fully recovered phase, and you can see his proximal tubulars are back to normal with just some scarring left behind. And so again, those are the three phases of ATN. This is the PNS, the pale and swollen. And then let's move from there to nephrotoxic ATN. So remember we said ATN, ischemic, and toxic. And so there's a lot of different toxins here. Many of these toxins, we can kind of discuss them briefly. There's the heavy metals, mercury exposure, lead exposure, gold, arsenic. Fortunately, it doesn't happen often, but these can injure the tubules. There are certain organic solvents like carbon tetrachloride and ethylene glycol, which is the main substance in antifreeze. And then there's a whole bunch of drugs. And so really a lot of the toxic ATNs are really drugs. Antibiotics like gentamicin, antivirals used for HIV such as tenofovir, chemotherapeutic agents such as cisplatin. Those are three of the more common ones, but there's quite a few here. And then keep in mind, I mentioned already hemoglobin, or I didn't mention hemoglobin, I mentioned myoglobin, but also hemoglobin. These are natural pigments within your body that can, be the toxins when released in massive amounts. Abnormal levels of physiologic substances. That's what I'm talking about. So the pathology of nephrotoxic ATN is at its core similar to ischemic ATN, but there are some toxins that have a distinctive appearance where you can say, hey, that's not just ATN, but that's ATN due to X. And so this is an example of that. And this is actually a real-life case. You guys may not know this, but the armory next door where they have all these track meets, if you go back about 20, 25 years, was actually a homeless shelter. And so the neighborhood was a little bit different back then because a lot of the patients who lived in the shelter needed some place to spend their time during the day, and so they would sort of be hanging out in the neighborhood. And so it created a slightly different feel around here. And this was actually a patient who was an alcoholic living in the homeless shelter who came out and was looking for some alcohol, and he saw a bottle on the ground, and it was blue, and it smelled like alcohol. It was actually sweet, tasted pretty good, so he drank it. Unfortunately, it was antifreeze, and that's ethylene glycol. And this is what can happen. It has a very distinctive appearance, and that distinctive appearance is that the tubules, and you're going to say, why is it dark? And I'll tell you in a second, but the tubules look very damaged here with these big vacuoles present in their cytoplasm, loss of brush border. But we're looking at this under polarized light, and under polarized light you get these big oxalate crystals, calcium oxalate, that polarizes, and this is very, very distinctive. So if you see ATN with lots of calcium oxalate, antifreeze. That's the question, okay? Think of antifreeze. Think of ethylene glycol. Next one. Another form of ATN that has a distinctive appearance, and this is what we call an osmotic nephrosis. Now think about that name for a second. Nephrosis, forget that part, but it's an osmotic injury. So what happens here is that this is, again, an ATN with a distinctive appearance that points to a specific etiology. There are certain agents. This used to happen with older radio contrast agents, let's say for someone getting a CAT scan, where there are certain agents where you take in, but these agents create an osmotic gradient. And so they'll get filtered at the level of the glomerulus, they'll reach the tubular lumen, they'll get absorbed into the proximal tubule, but they'll get stuck there. And when they get stuck there, they create this osmotic gradient which sucks water into the tubular epithelial cell and doesn't release it. And so the tubular epithelial cells here are 2 to 3 times the size of normal. They're big and swollen, they're full of water, and essentially they don't function properly, and patients go into ATN until this over time resolves, the water is re-released, the osmotic agent breaks down, and they return to normal. And we do still see this from time to time. And then finally, and this is an important one, you know a little bit about, I'm not sure exactly how much, but I'm sure you know plasma cells and B cells make immunoglobulins. And immunoglobulins have light and heavy chains, and I'm sure you've covered this. And so sometimes if someone has a malignancy of plasma cells, which is what we call multiple myeloma, you can have massive release of light chains because you have this malignant clone that's just making light chains and making light chains. And so in your serum, you'll have very high concentrations of light chains. And those light chains can reach the level of the tubule and form these crystals within the tubular lumen that then often elicit this giant cell reaction. This is all within a tubule. But this idea that light chains from a malignant plasma cell neoplasm can precipitate as these intratubular casts is a very distinct entity which we call light chain cast nephropathy or myeloma cast nephropathy. But again, it makes the point, normally have some light chains floating in your circulation, no big deal. You throw a huge abnormal amount of them and that can be the toxin. So this is essentially can be thought of as a toxic form of ATN.
So one of the questions is, what caused that patient's, the alcoholic's, AKI and acute kidney injury. And we had some votes for hypotension, which hypotension contributes to any nephrotoxin. Remember, if you add on a low blood pressure and you give a nephrotoxin, you do worse. And rhabdomyolysis was the major vote here, which makes sense. So why do we think this person had rhabdomyolysis? One, we had tender muscle groups. His calves were tender bilaterally. He was probably cutting off the blood supply to his legs. He may have been lying on one or leaning over on it so that he didn't have good blood flow to it. Two, if you look at the BUN creatinine ratio, we said in pre-renal azotemia, you have a disproportionately high blood urea nitrogen for the level of creatinine. The only thing that gives you the reverse, a disproportionately high creatinine for the level of BUN, is rhabdomyolysis, because you release creatine from muscle, which gets converted to creatinine. You release a lot of creatinine precursors from muscle when you break it down. So you actually get a high potassium, a high uric acid in the blood, but you get, if you look at the renal failure, remember that patient, he had a creatinine that was much higher than his BUN. Third, urinalysis. You dipsticked his urine. It was positive for heme. Well, that's what the little dipsticks are looking for, blood. But myoglobin picks up just as well as hemoglobin on it. He had no red cells in the urinalysis. He was 4+ positive for heme. He had myoglobin. And if you checked a muscle enzyme, a CPK or an aldolase, which we normally would, they would be astronomically high, and it would say there's muscle breakdown, and indeed this is rhabdomyolysis that's doing it. But neither the hypotension nor the rhabdomyolysis was wrong. The leptospirosis was wrong, yes. Okay. So that's why we think this person has rhabdomyolysis. Okay. Now, just a second point, that Glenn doesn't like coming to my lectures, so he didn't see the slide on the mortality, the recent mortality in AKI that I showed back during that lecture with the 40-something% mortality still in all the countries, including the U.S., but whatever, for recovery phase, yes, if they have mild AKI, they recover. This guy would be in big league trouble. So we can go back, for your mortality figures to that first lecture on AKI. And the other comment I would make is, remember that day, I showed you the picture of Cousin Helen and Grandma Alice to start out. I showed you the picture of those two older ladies who came in, and we described one as the case of AKI and who eventually had ATN with gentamicin. But I told you, I had a 43-year-old who had just come into the hospital, who had cellulitis, was in the hospital, got aminoglycosides, and had AKI, and the creatinine had risen up to 4. Well, I can give you the follow-up. After 3 days, creatinine started coming down, just like Glenn described. Urine output was good here. That the creatinine came down. His next creatinine was 3-something. The outpatient creatinine is 2-something. So he is recovering from his nephrotoxic, in that case it was vancomycin, but again, and gent. But again, he's recovering entirely. So anyway, that's AKI due to ATN. Let's go on to the second case here. This is a 65-year-old retired OBGYN doctor who's referred by a New York City nephrologist here for presumed rapidly progressive glomerulonephritis. Now, you're all experts on that because Vivette told you all about it yesterday. His past history is hypertension for 40 years, controlled on a bunch of medications. He's had an arrhythmia, probably atrial fib. He's been given verapamil to control both blood pressure and the arrhythmia, and he's been hypothyroid, treated with thyroid. So he's on a usual bunch of medicines that older people, he's younger than I am, but he's on a bunch of medicines that older middle-aged people are on. He has some urinary urgency for a week. He goes to his urologist for a checkup. His urinalysis is normal. He has an urticarial rash on his legs for several days, which goes away. 1 week prior to admission, he gave blood, and the same day he played golf. Now, no internist, no pathologist would do that on the same day, but guy's OBGYN, we can excuse it. Okay, he's not feeling well, he's thirsty. He checks his Chem 7 to look what his BUN, his creatinine, and his electrolytes are. His BUN is 94 and his creatinine is 4.4. He goes to his friend who's a nephrologist, gets a recheck, BUN 91, creatinine 4.9. His potassium is way up at 6.7, which can be life-threatening. His albumin is normal. His white count, his hematocrit, platelets are all normal. His urinalysis had some red cells, but no casts, okay? He has negative serology for ANA, for lupus, anti-streptolysin O, and urinary immunofixation, thinking of myeloma, negative, etc., normal pattern there. They measured a clearance. There'd be no reason to do it because, again, if it's changing, it's very hard to determine the clearance. His medicines are, as we said, he's taking the verapamil, he's taking a proton pump inhibitor for his acid reflux, Zoloft, Synthroid for his thyroid, and Cozar, a blood pressure medicine. He's given Kayexalate, which is a resin that removes the potassium so he's not acutely in danger, and he's referred to Columbia for evaluation of a kidney biopsy. Does he have RPGN? His blood pressure is 170/90, pulse 82, heart, chest, abdomen entirely negative, no edema. He has a fine maculopapular rash on his chest and upper arms. We check his BUN and creatinine, 96 and 5.1. His potassium now is okay, so we're out of the woods there. He has only trace protein, 2+ heme, no casts. Okay? So, again, what is the differential diagnosis of acute renal failure, AKI, pre-renal azotemia, post-renal? You can get an ultrasound, rule out post-renal azotemia. You know the guy's well hydrated, he's not in heart failure, you don't think it's pre-renal azotemia. Then you think of 4 things in the kidney. Blood vessels, is it a vascular problem? Tubules, is it ATN? Did he get hypotensive when he was playing golf after giving blood? Is it acute interstitial nephritis, the area between the tubules and the glomeruli? And is it acute glomerulonephritis, RPGN? We don't have red cell casts, we don't have anything etiology to go for that or any other findings. And again, we've already looked at some of the laboratory tests. We could do other serologic tests like ANCA, etc., if we really thought it was an RPGN. Okay, how many people want to do a biopsy now? Okay, good. Yeah, this is good. Okay, you could wait and consider the biopsy if he doesn't recover, but his creatinine's already getting up there. And if you wanted to wait a short while and see if he recovers and that it may be ATN from the hypotension that he had after giving blood and playing golf a week ago, that's possible here. On the other hand, you wouldn't wait a long time before the biopsy. So this is what he has. Now, I'm not giving anything away because you normally have to be pretty good to look at other parts of the kidney than the glomerulus, but we have a good pathologist, so.
Dr. Garrett, I want to propose an exam question for you. Based on Dr. Pell's lecture so far, I want to propose an exam question for you. It would be, would you biopsy this patient? And the correct answer would be yes. As a pathologist, I think it's a great idea. So we started out with ATN, and now which is a tubular cause of acute renal failure, and now we're moving to acute interstitial nephritis, which is an interstitial cause of renal failure. And so the main pathology here is in the interstitium, and here in the interstitium you're filled with inflammation, and you're filled particularly, it's a mixed infiltrate. You have lymphocytes, you have plasma cells, but I do want to make the point that you see quite a few eosinophils here with their beautiful red granules. Here's another example, and the defining pathologic features of interstitial nephritis are inflammation in the interstitium, and you got a lot of that here. The second thing is that you would like to see this inflammation extending over or across that tubular basement membrane on top of the tubules. So these nuclei, which are sort of pushed up, that are sort of blue and somewhat see-through, not particularly dark, are the tubular epithelial cells. All of this beneath it are the inflammatory cells, lymphocytes, eosinophils. And not surprisingly, inflammation of the tubules is called tubulitis. And so interstitial inflammation plus tubulitis is the hallmark of interstitial nephritis. And if you see that combination, the one thing you always want to look for is eosinophils, because as Dr. Appel's going to tell you in a few slides, the majority of cases of interstitial nephritis are drug-induced, about 70%. But if you see a lot of eosinophils, it even goes up higher that it would be allergic or drug-induced. So this is drug-induced. An example, Dr. Appel's patient has drug-induced interstitial nephritis. This is a cell-mediated hypersensitivity T-cell-driven reaction. The findings you will see are interstitial inflammation. You may see some interstitial edema. you see tubulitis, and if you see eosinophils, that really, you don't need to see eosinophils, but if you see it, it really pushes you towards the drug-induced etiology. And finally, I would just say we're not going to cover the topic of granulomatous interstitial nephritis, which has a slightly different differential where you start thinking of things like sarcoidosis, but I would just tell you that granulomatous inflammation is often part of a drug-induced interstitial nephritis.
So this is a very important form of AKI. Just like everything else, knowing the pathophysiology and knowing the pathology can help you tremendously. In ATN, we said a lot of times we just don't get a biopsy. We don't need the biopsy. But here, we clearly do to confirm what it is and then to treat the patient. So we've put here the clinical features of penicillin-related AIN, acute or allergic interstitial nephritis. It's a prototype. There are many drugs that do this. This is a classic. There are hundreds and hundreds of cases in the literature in terms of this. Even though there are millions and millions of people taking penicillins, it's a small percentage. But if they have these clinical features and they have acute kidney dysfunction, yes, you think of it. And what are they? Rash, fever, and eosinophilia. The rash we'll look at. Fever, they defervesce from their original infection, and then all of a sudden they spike a fever again 2 weeks later as they develop renal failure and have their interstitial nephritis. You saw eosinophils in the kidney. They have eosinophilia in the blood as well. But only about 30% of them have the full triad. So you have to think about this. If you have somebody who's on a beta-lactam, cephalosporin or penicillin, and they develop acute kidney injury, often if it's non-oliguric especially, then you think about, do they have rash, fever, eosinophilia? Could this be AIN? Here's the typical reaction. This is a case of amoxicillin interstitial nephritis, and the rash is typical maculopapular morbilliform. You'll see 1,000 patients with a penicillin rash for everyone that has interstitial nephritis in the kidney. Nevertheless, when they get the interstitial nephritis, they often have that classic rash. Looking at the urinary findings can be very helpful. They have very little proteinuria. It's not a glomerular disease. They often get hematuria, especially in kids. They get hematuria with this microscopic and sometimes even gross as they get their interstitial inflammation. Sterile pyuria, not too helpful. Eosinophiluria. They have eosinophils in the kidney. They have eosinophils in the blood. They have eosinophils in the urinary sediment. This is just a right stain of urinary sediment. You can see the binucleated eosinophils. This is a case of allopurinol interstitial nephritis. Again, if you find lots of eosinophils in the urinary sediment, you have the right setting here, you can say, hey, this is likely to be interstitial nephritis. We often like a biopsy because we often treat these patients with steroids to get rid of the inflammation. So, medication-induced acute interstitial nephritis, any beta-lactam antibiotic, penicillin or cephalosporin, a number of other antibiotics, sulfonamides, rifampin, the quinolones, the floxacin, ciprofloxacin, ofloxacin, moxifloxacin, etc., all of them can do it. Diuretics, non-steroidals can do this, then a variety of other medicines infrequently. Proton pump inhibitors are becoming more and more common causes of this. Now, it's interesting, little anecdote, I got a call from my brother yesterday, who's a nephrologist. He's referring over somebody that he referred over somebody, and I was out of town. One of my colleagues saw the patient. We did the biopsy down here. It was AKI. It turned out interstitial nephritis due to proton pump inhibitor. And he was saying, you know, that's the first biopsy case, proven case I've seen, but it's actually becoming more and more common. Many people take these proton pump inhibitors. You know, that's omeprazole, pantoprazole, that whole group of them, and they, again, small percentage will develop AIN. So what happened to this patient? We stopped all medications and used alternatives. We didn't have to use any of those. It wasn't clear. Actually, he is the first case. This is an older case. It's the first case of a proton pump inhibitor that I had seen. And we stopped that. Even the proton pump inhibitor was stopped. We gave him antacids orally. We treated him with prednisone at a high dose for just a short period of time, 6 weeks. His creatinine went down from 5.1 all the way down to 1.8. And at least in a 4-year follow-up, he had absolutely stable function in terms of this. So remarkable improvement, knowing that that's what he had on the biopsy. Now, at the time, proton pump inhibitors were not considered a cause, but they obviously were. So here's an add-on slide. Glenn added this on, and I think it's a good idea. If you take all causes of acute or allergic interstitial nephritis here and look at them, drug-induced is overwhelmingly the most important. There are a lot of other causes in here. Idiopathic makes up some, but the biggest group by far is drug-induced. So when you see that, think of the medications. We're doing it to the patient. So that slide will definitely be included again next year. Okay, we're ready for the third case. A 64-year-old diabetic has mild hypertension. Her blood sugar has been poorly controlled recently. She's had polyuria and nocturia due to the glycosuria. Recently, she's noted burning when she urinates, and she's going to urinate frequently. She develops fever, chills, and left flank pain, which keeps increasing over 24 hours. She calls her doctor, who sends her immediately to the emergency room. Her blood pressure is 110/70 there, pulse 100. She has a temperature of 102. Okay, she has marked tenderness at her costovertebral angle area on the left. BUN is 35, creatinine is 1.4. White counts up at 16,500. Her hematocrit and platelets are normal. She has 3+ glucose in the urine, 2+ heme, trace albumin here, 10 to 15 red cells, but too many to count, too numerous to count white cells. It's just filled with white cells, and there are white cell casts. Remember, red cell casts always tell you it's glomerular disease, but now we have white cell casts. Her urinary sodium is 42, the fraction excretion is 1.8. She has no blockage on her ultrasound here, but it's likely that there's a stone in the left kidney. They see a shadow. They're cut off in a shadow, like I showed you the other day. She's treated with hydration, antibiotics. Over the next 24 hours, her blood pressure rises up, her temperature comes down, and her urine output remains good. The BUN decreases to 14, the creatinine to 0.7. Significant improvement. Here again, this might be her kidney. It's not, but it might. Cut off, shadow, cut off, shadow. Those are stones. And here's what we see in her urine sediment. Here's a cast. It's in the shape of a tubule. These are all white cells now, as opposed to red cells. So Glenn's now going to tell you what's going on in the kidney. This is not a common thing to biopsy. It could be a biopsy I did by mistake, but Bruce and I gave also this.
So, just want to make a basic point up front, which is that, let's just go back a slide. Oh, don't want to do that. So, if you notice in the history that was presented to you, the creatinine was 1.4 and then went back down to 0.7, right? So, just broad terms, I want you to think about something. We talked about ATN as a tubular cause of renal failure. We talked about AIN as an interstitial cause of renal failure. We're now going to talk about infection of the kidney. This is what we call pyelonephritis, right? This overwhelmingly is a unilateral process. Unilateral processes in the kidneys don't really change renal function. If I go and donate a kidney to my brother tomorrow, a week from now, I will probably have the same creatinine that I have today, and if anything, it'll go up a marginal amount, like 0.2, and then just stay there. And so the point being that the one thing that's a little deceptive about the history I just presented, it seemed like the patient had renal failure. Overwhelmingly, inflammation of the kidney is unilateral, and when it is, it doesn't change renal function. But anyway, let's get back to this case. And so what you see in acute infection of the kidney parenchyma, bacterial infection, what we call acute pyelonephritis, is this abundant inflammation, like an interstitial nephritis, and a distinctive feature is that there's many neutrophils, you can see here, but a lot of the neutrophils gather in the tubules, and we call these neutrophil casts because it's a big aggregate of neutrophils kind of stuck together. And here is a higher power view of these neutrophil casts. This is what we see at acute pyelonephritis at autopsy. So this is a patient who actually died of acute pyelonephritis, and each of these yellow nodules is what we would say is essentially an abscess. These are necrotic abscesses forming in the kidney. The truth is, this is a dramatic picture. It's great to show it to you. It would be very unlikely that a person could live to have this many abscesses. You would be so septic that you would more likely expire long before it could get this severe. This is a very dramatic example. So acute pyelonephritis is an acute, suppurative, neutrophil-rich infection of the kidney. Patients typically present with back pain, fever, white cells in the urine, elevated white count in the serum. But renal insufficiency may not be present, and if it's present, it might just be because they're so infected that they're just very sick and they have a low volume and they have like a little bit of ATN or something like that. And urine cultures are really critical here because you want to confirm the diagnosis and you want to know what's the best antibiotic for this patient. It's also critical not to biopsy. It is only going to produce complications and problems. And so you will hopefully never see this on a biopsy. We do rarely. In terms of how the kidney gets infected, there's two routes. It can be ascending, meaning it travels up the GU tract, or it can be hematogenous, meaning it comes from the blood flow. Ascending would start in the bladder, usually as a UTI that doesn't get better, and ascend upwards. This is much more common in women than men, partly because of the very short distance of the urethra, and therefore they have much more higher incidence of bacteria from outside being introduced inside and forming UTIs, and so if they're going to have more likely to have UTIs, they're going to be more likely to have pyelonephritis. Whereas from the hematogenous route, where you're talking about bacteremia or septic emboli, it's really equivalent in terms of incidence between men and women. In terms of the organisms, 85% of it's gram-negative bacilli, number one being E. coli. These are usually the same organisms that are present in the fecal flora. In terms of acute pyelo, there's increased risk of this ascending infection. So we're talking, again, most of these cases are ascending, therefore it's more common in women. And so what are the situations that have increased risk of this ascending infection producing acute pyelonephritis? And there's really three settings. One is obstruction. So anything that obstructs the normal outward flow of urine has the potential for urine to be sort of static, to sit around, to become infected. So a very large prostate in a male, a large tumor somewhere obstructing the GU tract. Pregnancy, where you essentially have a big growing mass that can impede urine output. And finally, diabetics who have these neurogenic bladders that really don't empty properly and they become large and dilated, and again, there's a lack of normal urine flow. So anything that obstructs flow. Second is anytime you introduce an instrument from the outside to the inside, for instance, leaving in a Foley catheter for a long period of time, it would be a place where bacteria could travel from outside to inside. And then finally, the third big category here is vesicoureteral reflux. Now, vesico vesico basically means bladder. I don't know the exact derivation, but it means bladder to ureteral reflux. And so that's the combination, that's the concept that you would have infection in the bladder that instead of when the bladder emptying, it goes back up, refluxes up the ureters. And it turns out this is sort of an interesting story, so we're going to talk a little bit about this, which we can also call VUR, vesicoureteral reflux, because it's actually present about half the time when you see a UTI in a child in the first year of life. Now, fortunately, you don't see a lot of UTIs in a kid who's under a year of age, but if you do see it, you should always think about VUR. And VUR is essentially a congenital anomaly of how the ureter inserts into the bladder. And so what I mean is the following. In the normal condition, the ureter, as it enters the bladder, this is the bladder wall, has this sort of long oblique course, and now it empties into the bladder. And the reason it doesn't go straight through, but does this oblique course, is because when you squeeze the bladder to urinate, it squeezes down and closes the flow so that urine does not go back up. But if you had what would seem to be the shortest distance straight in, then when you increase that bladder and the pressure in the bladder, the urine can go straight back up and cause reflux. And so that short intravesicular ureter, or the short segment of ureter within the bladder wall, sets you up for this development of UTIs in these young children. In terms of acute pyelonephritis, grossly the kidneys are usually normal size. You may see some abscesses. I showed you an example with more than you'll ever see abscesses. Microscopically, you see inflammation, particularly neutrophils. You can see little abscesses microscopically. You see neutrophil casts and some inflammation of tubules or tubulitis. If it is ascending, you'll see it more concentrated by the medulla and appearing to extend upward. If it's from a hematogenous route, it would really start out in the periphery of the cortex. Most cases, as I said, are ascending. So moving off of acute pyelo to chronic pyelo, and you might say, doesn't acute pyelonephritis become chronic pyelonephritis? It's really not that simple. Most patients with chronic pyelonephritis don't even know that they ever had acute pyelonephritis. And so this presents more as a chronic renal disease with scarring and inflammation and deformity of the calyces and pelvis, and this also results from ascending infection. And in fact, a lot of times it's those kids with VUR or with reflux that have this chronic reflux producing scarring in the kidneys, and they'll never have an episode of acute pyelo where they have fever and a high white count and they really feel very sick. But they'll have this chronic scarring with sort of subclinical infections, and you'll end up with these kidneys that are grossly shrunken with irregular, asymmetric, broad, flat scars. We call these U-shaped scars, and that gets emphasized in your gross lab, hopefully. That's these broad areas, not just a little V-shaped scar, but these broad U-shaped scars with papillary blunting and deformity of the calyces. And here the pathology is different too. You'll have this disproportionate tubulointerstitial scarring. It will not be neutrophils, it will be mainly lymphocytes, but you'll have this very particular type of tubular atrophy, which I'm going to show to you in a moment. So another interesting point here, when you have that refluxing urine going back up to the kidneys and creating this pressure in the wrong direction, as it hits the midpoints of the kidney where you have these simple papillae, that increased pressure will kind of collapse these papillae closed, and so they will not get maximally scarred. But at the upper and lower pole of the kidney, you have these compound papillae, where that back pressure may shut off, if you will, or clamp down on the sides, but in the middle, it'll come right at it and cause that scarring. And so usually, when you have a chronic pyelo due to that reflux, you'll have maximal scarring at the upper and lower poles. It's a little bit more theoretical than what you actually always see, but it definitely is something you see sometimes, and it's worth understanding. And this is an example of a broad U-shaped scar that's not occurring at the poles, but in this particular case occurring in the mid-portion of the kidney. So in terms of chronic pyelo, it is often, it can be very insidious. You're only going to really get renal insufficiency if it's on top of something else or it's bilateral. Usually you will have a bit of hypertension with this. You can have a little bit of proteinuria. You may not concentrate your urine normally, and you will usually have culture negative, no bacteria in the urine, and it rarely follows a usual course of acute pyelo as we previously discussed. It more commonly will be seen in patients with persistent obstruction or that reflux, and you may never be aware of any acute episodes. The way to treat this is to relieve the reflux. And so there may be, for instance, those kids with VUR, they could do surgery to reinsert the ureter in a way to prevent the reflux, and so there are surgical options and antibiotics when necessary. And this, again, is an example of these U-shaped scars of chronic pyelo. This is what chronic pyelo might look like under the microscope. Again, this is not something you biopsy for. This is something that's much more of, let's say, we might learn about this at autopsy. Here you have 5 glomeruli that look fine, overwhelming inflammation. That's clearly a disproportionate tubulointerstitial involvement. And then this is a very distinctive type of tubular atrophy. So this is the renal capsule. This is a blood vessel here. And these are all very, very much atrophic, damaged, ineffective tubules. But they have a very distinctive appearance, which is that they look big and dilated and contain this proteinaceous material that looks like colloid in the thyroid. And so therefore we call this thyroid-type tubular atrophy, and we say thyroid-type tubular atrophy is most commonly seen in chronic pyelo, or really kind of associated with pyelo, although I would not call it pathognomonic. And this is that calyceal blunting and scarring. And you can see this was clearly with this dilatation here, clearly a case that was ascending with more pyelo out there. This is the way you diagnose VUR, or one of the ways you diagnose it. It's usually a congenital condition. You insert essentially dye into the child's bladder through a catheter, and then in a normal voiding cystourethrogram, all that dye goes right back out. An abnormal study is one where the dye is getting reflux all the way back up into the kidneys. This is a very dramatic example. These ureters are probably 10 times the normal diameter. and you can see a severe case. Again, this is a congenital condition and it underlies 50% of UTIs in kids under the year 1. And here's the pathology with very dilated ureters, really tremendously scarred and thin cortex with dilatation of the whole collecting system. It's case number 4.
Perfect timing. Okay. The last case is a 52-year-old female who's had rheumatoid arthritis for 20 years, has been taking aspirin, Tylenol, and nonsteroidals, but no other medications. She develops flank pain, but no fever, chills, or dysuria. Remember, our last patient had flank pain, but she also had fever and she had dysuria. Physical exam shows marked deformity of her joints, sort of like the joints that I showed you the other day in terms of the glomerular case, but no edema. Her urinalysis has trace protein, few RBCs, but many white blood cells. Okay? So do you think this is a glomerular disease? There's no proteinuria, there's no red cells, red cell casts, unlikely. Her BUN is 32, her creatinine is 2.4, her 24-hour protein is only 400 milligrams, 0.4 grams a day. Okay, that's abnormal. It's a little abnormal, but certainly not in the range that you expect for most glomerular disease. She has negative or normal tests for complement, anti-DNA antibody, hepatitis B, blood sugar, hepatitis C, etc. The urine culture is no growth. They said maybe this is pyelo. There's no growth at all in the urine culture. An intravenous urogram is performed. You inject contrast and watch it excreted by the kidney. And here you can see the collecting system here. Here's the ureter coming down, not dilated up like reflux, but here you see these little excrescences all over the place here, okay? So what is going on in this person's kidney, okay? Is this bacterial pyelonephritis? No fever, no dysuria, and a negative culture? Unlikely. What are the other possible causes? What other diseases could cause this picture, especially in somebody with long-standing rheumatoid arthritis who's taking the following medications? Well, let's turn to the pathologist.
Don't go into it, so maybe like 30 seconds.
Right.
So basically the entity here is one which we call papillary necrosis. And when you look at this kidney here, and this is bivalve and would normally let's say be closed up, what you see here is the tips of the renal papillae. There's necrosis. That's why we call it papillary necrosis. There's another kidney, again, showing you this brown necrotic material at the tips of the papillae. So Dr. Pell's going to tell you a little bit more about papillary necrosis and the causes.
So this case of a rheumatoid patient doesn't have a glomerular disease. Instead, they have a tubulointerstitial disease. If we look at papillary necrosis, one of the common causes is analgesic nephropathy. It's an international disease. It's seen in many different countries, typically in people who have long-standing headache and arthritis. And we talk about abusers who overdo nonsteroidals, phenacetin, acetaminophen, etc., but also people who are prescribed it. In the past, it was very highly female to male. Now the ratio is getting closer to 1-to-1. You need to take large amounts for a long period of time. If you're taking a couple of Tylenol a day for a few days, nothing. If you're taking Naproxen, Motrin, any of these Advil, don't worry about it. But if you're taking many a day for 3 years, you're at risk for developing this. You have sterile pyuria, white cells in the urine, mild proteinuria, mild hypertension. It's not a glomerular disease. Glomerular diseases give you hypertension, fluid retention. This doesn't. There's decreased concentrating ability, decreased net acid excretion, salt wasting. These people get volume depleted. They constantly have polyuria and nocturia. And at the end stage, the worst part is they necrose the papilla because the damage is in the medullary area here. One of the important things is the patients can recover a lot of function if you stop the analgesic use. So what are the major causes of papillary necrosis? Sickle cell disease with sickling in the medulla here and medullary ischemia. Obstructive pyelonephritis, if you have stones and pyelo and you damage the interstitium, you saw the damage that you get there, eventually you'll slough off the papilla. Diabetes, bad diabetes can do this. Analgesic abuse is an increased risk with combinations of acetaminophen, phenacetin, etc., and some direct toxicity. But the way to remember it is soda, okay? Dr. Garrett, you got that? Soda. You know, okay, just in case. Anyway, so that's how the radiologists remember it, and if you find it on an ultrasound, if you find it on an IVP, a CAT scan, it is strongly suggestive of one of these different etiologies. Last slide, nonsteroidals. Nonsteroidals, which we talk about a lot, can cause acute interstitial nephritis. That was on the list with inflammation. They can cause acute tubular necrosis here because you block your prostaglandins. So somebody who's hypotensive, who takes a lot of nonsteroidals, will develop this. They can actually cause, rarely, a form of glomerular disease, minimal change disease. It's one of the etiologies we think of. They can certainly cause papillary necrosis, etc. So nonsteroidals can cause a lot of problems. When you're looking at the history of your patient, you look for nephrotoxins, you look for antibiotics, always think of nonsteroidals on that list because they can damage the kidney in many places. So we're taking a 10-minute break now, and then we're coming back for the last part of this, vascular disease.
Glenn, that was perfect.
I wrote it down as soon as you made the comment. I'm just going to say the majority of the comments. You're using API to change your API. Probably higher than that. So what I'll do is I'll change the 90% to majority. That's what I wrote back up now. That's good. I still think it's 80.
Well, these slides are probably not up, is that?
So I can change it.
Oh, they should have been. I sent
Let me
them.
change it. Let's see. 80 to 90. Let me change majority to majority. We're actually going to insert a slide next year that tells it's going to say
Okay. So Barry, yeah, we're good. Oh, yeah. Oh, yeah. I have to go over when the breaks are. Okay. So let's see.
So you start. So
I start. Yeah.
Teaching the case one. So
Right.
I'll do the pathology.
Yeah.
And I'm thinking.
Oh, you already have a copy. If you have a
yeah.
copy. Oh, fine. That's good. So you have a copy. That's great. I'm using my old. I already have it on my old copy. That's right.
I was just going to let you guys know that this...
You have a question? You have a question?
Oh, yeah. Wait, I have a question. This is that one that's filtered earlier.
Giants.
But no,
Were you a college athlete?
Oh, no. It's related, right? Creatinine is it's filtered and secreted, right? Or it's just filtered? Because I was wondering why if you have an extra disease, why did your creatinine even go up at all in the first place? Because you still have the same amount of P, right? You did the teacher the same amount of creatinine.
Sorry.
Is creatinine filtered and secreted?
Yes.
Okay, so it's
Okay.
not like...
So, yeah. So there is 10%
is secreted. 90% is normally filtered. As the GFR goes down, if you have severe renal dysfunction, the secreted part often stays about the same. The filtered part goes down, so it adds a little bit more to it. But usually it's not relevant. The only time it's relevant is there are certain drugs that block the secretion of creatinine. So it turns out trimethoprim sulfate, trimethoprim in backup does that. And sometimes you get a slightly elevated creatinine. Your creatinine
Is it just saved on the desk?
Yeah, it's this one.
But that's because you're on the drug. It's not changing your GFR. It's not changing your kidney function. It's changing, blocking that secretion of creatinine.
So why does like if you have a AIN, if you don't have the GFRs are the same, why is the creatinine rise?
Yeah, so what happens in AIN is that the interstitial inflammation pushes on tubules, so you get increased back pressure, you get lots of cells in the tubules, you get obstruction, you get tubular blood. All the things that happen in AKI can happen in AIN, and which leads but it's mostly pressure on the tubules. The tubules are just all filled with cells like now.
And you were saying that if you lose one kidney, your other kidney compensates, right? So you have the same amount of creatinine.
So the creatinine often goes up a little bit. If you donate a kidney to somebody, your brother who needs a transplant, your creatinine may go from 1 up to 1.3, something like that, 1.2, 1.3. And we know the remaining kidneys, as increase DNA synthesis, RNA synthesis, protein synthesis, immediately starts doing it. Gets more of the blood flow and does more.
But it takes a lot. I'm wondering why acute pilot, why do you have dysuria? Should not just compensate from the acute output?
The trouble is that with a pilot, almost all these people are febrile and really sick. So they're hypotensive as well. So they really can't perfuse the other kidney quite as well. If you have on one side, your creatinine, you don't go into, you don't get a creatinine of pilot. If you get a creatinine of 8 of a pilot, it's because of the hypotension and sepsis.
I guess if you have phyllo, why is it considered AIN?
Well, some people use the broadest definition of interstitial. It is a form of interstitial disease. It is. I mean, the thing is that it's not a common cause in the United States. Acute pyelonephritis is a common cause of infection in the United States. People usually barely don't.
I saved it as a PDF, so that's easy to take those on anyway.
Here, AIN drug is overwhelming. You go to London, East London, they present cases of TB and every bacterial infection in their immigrant population. So, here, take our most indigent population, who doesn't have access to antibiotics. Just, generic antibiotics are just so cheap that, and everybody will go to an emergency room, when they have dysuria.
And one last question, why would you give victimizing to that person?
I have to delete some old emails.
It would probably be a much better idea to use it if you did. That would not be what I would do. I would not give a nephrotoxin, but it just gave more choices as to what could cause the problem. And there, of course, the answer was that gentamicin wasn't given until the creatinine was really elevated, so it couldn't be causing it.
Hi, I have one of those silly questions. So, personal, but how long would it take for an overdose of NSAID to really affect the kidney?
Usually, overdoses of NSAID, just continued overdose, unless you get hypotension, so one, overdose
Okay, I'll just forward it from my thing so we can get on with the live.
Are we trying to get this online now?
Yeah. I'll work on it from there. So
Let's see. Do I start, Barry? Do I start on this one, right? Yeah, okay. So I'm going to tell them that we're getting this online.
Yeah, I wonder what happened. Betty's usually pretty good about this.
I sent you a copy.
Oh, no, I think you were the first one to say that, because I know that, we had the conflict of interest stuff, so.
I'm giving him 2 more minutes because I'll talk quickly if Glenn was fine on this one. I mean, no jokes. I mean, what happened was I told him to slow down when I went out to get my coffee because I wasn't sure how, but it turned out it was really fast, so then we sort of picked up again. Now, if we're going to do this again next year, I'm going to switch around some of the slides. Like, we have a lot of slides, unless they change it, but I'll look on the German epidemic, which now I've narrowed down to just 2 or 3 slides when I do the TME talk and for Bud's course. So, and I put in some newer data on antiphospholipid control. I mean, I'll revise my part. Your, pathology hasn't changed, so. Okay.
Okay, let's all settle down and go through one more area there. Okay, now it has been pointed out that this lecture is not online. I want to say this is not Dr. Appel's fault. It's certainly not Dr. Stokes' fault because he was the first of the pathologists to send me the stuff and say we're getting it online, and he certainly sent it through. So I don't know who you blame, but don't blame us, but we're trying to get it online now anyway. And if anybody wants to bring a thumb drive and copy it, we're happy to do that too. But I think we'll get it online by the time this lecture is over. So this is my 3rd lecture this week. This is my 3rd pathologist. I mean, we're running through pathologists almost as fast as lectures. We're going to talk about vascular disease, and we have Barry Stokes to do this with me here. Okay. You're going to know all my... as always, the pathologists... The pathologists never have any conflict of interest, which is absolutely amazing to me. How can they bring any money in grants for the university? The dean's going to fire you guys. Anyway, teaching objectives, okay? Differentiate the major causes of thrombotic microangiopathy, TMA, based on pathogenesis. Identify for using certain newer drugs like complement inhibitors and atypical hemolytic uremic. Recognize the major manifestations of antiphospholipid syndrome, and then recognize how large vessel arterial disease can cause both acute and chronic renal disease. So the first case is a 4-year-old female child who goes to a petting zoo with her parents. She cuddles the sheep, the calves, and the other baby animals. She does not wash her hands immediately afterwards. 3 days later, she develops abdominal cramps, diarrhea, and bloody stools. She has nausea, vomiting, fever. She's given antibiotics by her pediatrician. Day 6, she develops ecchymoses, black and blues, all over her extremities and her lips. She's anemic. Her platelet count drops down. She's thrombocytopenic. She develops oliguria. Urine output drops down dramatically. They check her stool. It's positive for E. coli 0157H7. So this is a very unfortunate common occurrence. Now, it's occurring less. I mean, I don't know how many of you have young kids, but a lot of you very shortly will have young kids. And I can tell you from the grandchildren, petting zoos are unbelievably popular. Now when I go to a petting zoo with the grandchildren, my daughter-in-law gives me all these wipies things. I mean, if they touch anything, they touch us, we have to wipe their hands. So, and it's important. There's a good reason. You look at the blood smear on this child, and it shows schistocytes. These are fragmented red cells. Here you can see them at the arrows here. They're broken in half. That is red cells that get sliced apart as they go through this thrombotic mesh in the small vessels, such as the kidney and glomeruli. So what do we find on the kidney biopsy of this patient? Barry will tell us.
So this is a disease that affects the vasculature, and as you remember, the glomerulus is basically a modified capillary. So we see a lot of pathology in the glomeruli in this condition, as well as in the small arterial vessels. And the distinctive features here in the glomerulus is the presence of red blood cells and fibrin thrombi in the glomerulus. And in a severe case like this, all of the glomeruli will be affected. So you can't make out any glomerular capillaries anymore. They're basically all filled with this pink material, which is the fibrin thrombi, and then there are some red blood cells as well. So it's not a hypercellular disease like glomerulonephritis. It's a disease of the endothelial cell causing thrombosis. We can see these fibrin strands better with the trichrome stain. They stain red here. The arrow is pointing to it. And you've got red cell congestion as well. One of the terms we use as pathologists is glomerular paralysis. It's like the glomerulus just suddenly stopped filtering when this injury occurred. Here is a more segmental fibrin thrombus. Again, this is the hilar region here where the arteriole is coming in. Most of these glomerular capillaries don't have any abnormality, but down here we see segmental accumulation of fibrin, which is red and kind of fibrillar in appearance. So this is fibrin thrombus. This is diagnostic of this lesion. When you look at the immunofluorescence stains, there are no immunoglobulins or complement usually in this condition. The only thing we see is fibrin. So we stain for fibrinogen, and this is a glomerulus which is filled with fibrin, correlating with these thrombi that you see by light microscopy. If you do electron microscopy, this is what fibrin thrombi look like by EM. The arrows are pointing to these black structures are fibrin tactoids, or strands of fibrin. No immune deposits. This is the glomerular basement membrane out here, so this is all inside the glomerular capillary. It's an endothelial or intracapillary injury. And then sometimes, this is a very characteristic finding in the more chronic forms of this condition, the endothelial cells here lift off of the glomerular basement membrane. So remember, normally the endothelial cell is stuck onto the GBM. Here it's detached or lifted off, and we have an accumulation of this loose matrix underneath the endothelial cell. This is what fibrin looks like, or coagulation products can look like by EM. So the findings here pathologically, this is an acute thrombotic microangiopathy. What is thrombotic microangiopathy? Well, it's a pattern of disease characterized by endothelial injury. That's the key element here. And subsequent formation of thrombi, which consist of fibrin and platelets mixed together in the small vessels. So we see it in the arterioles and in the capillaries. We don't see it in the veins. This is, can result from many different causes. Basically, anything that injures the endothelium can produce a thrombotic microangiopathic picture. And the main clinical features are illustrated by this case. Because of this consumption of platelets and fibrin in the blood vessels, you get anemia, so the red cells are destroyed. You get thrombocytopenia because the platelets are all trapped in these thrombi. Schistocytes, which Jerry showed you in the peripheral blood smear, these are due to rupture or disruption of the red cells when they try to pass through these fibrin thrombi. They get fractured or fragmented. Useful lab tests, the LDH is usually elevated, reflecting damage to the red cells. Haptoglobin is decreased. And then you get a variable amount of systemic signs depending on which organ is affected at any given time. And the organ damage results from ischemia. So when you have occlusion of the blood vessels due to fibrin thrombi, you get ischemia of the organ. And commonly it presents in the kidney, which is why we're showing it in this lecture. But it can also affect other organs. The coagulation is not limited to the kidney. It can occur in the CNS, it can occur in the GI tract. So you can get infarcts in the brain, you can get mesenteric ischemia, and other organ involvement, including the skin. So that's just a general overview of thrombotic microangiopathy. So just here in the center, this is the vessel with TMA. Just to remember, it can occur from different causes. And we're going to review some of these in the course of this lecture. So on the top, the example we're showing first is an E. coli infection related TMA. These E. coli, particular type of E. coli, can produce a toxin, a Shiga-like toxin, which damages the endothelium. It can also result from either genetic or autoimmune disorders of complement activation, so either autoantibodies that interfere with complement regulation or genetic defects of complement regulation. All of those can also predispose to endothelial injury, leading to TMA. Severe hypertension, accelerated or malignant hypertension, just mechanically the extra stress on the endothelium can cause thrombosis. And then on the right-hand side, we're going to talk about these conditions. Antiphospholipid antibody syndrome, which we'll talk about in more detail. These are conditions that interfere with coagulation. And then finally, loss of anticoagulant. Normally, the body, there's a balance between coagulation and anticoagulation. If you lose regulators of coagulation, you can develop thrombosis. Clinically, we've recognized in the past two major syndromes of TMA based on how the patients presented. This was before we knew really what was causing these diseases. The first, which is what we're showing today in the first case, is hemolytic uremic syndrome. These are patients who present with uremic or kidney failure along with hemolysis, and it's abbreviated as HUS. So they have microangiopathic hemolytic anemia in the blood film, and they have acute kidney failure. The other broad group is TTP, thrombotic thrombocytopenic purpura. This condition, as the name implies, you see more skin manifestations, extrarenal signs, CNS manifestations, and renal involvement is rare, but it also shows features of microangiopathic hemolytic anemia and will show features of thrombotic microangiopathy in other organs, but not necessarily in the kidney. So our case, the first case, this is resulting from a Shiga toxin producing E. coli. So not all, E. coli is ubiquitous, it's very common. Certain strains produce a toxin. It's called Shiga-like toxin because it's the same type of toxin that Shigella bacteria produces. And this is toxic to our endothelium. So if you ingest these E. coli, you'll develop endothelial injury, which can lead to thrombosis. Final diagnosis in this case would be a Shiga toxin-related hemolytic uremic syndrome. What is the Shiga toxin? The other name for it is virotoxin because it is injurious to a certain type of cell, the Vera cells. It's got two main components. It's got A subunit on the surface which binds to a receptor on the surface of endothelial cells, which binds to ribosomes and inhibits protein synthesis, and it's got 5 B subunits on the surface of the toxin. These are the molecules that bind to the sites, the binding sites on the endothelium, also epithelium in the colon and white cells. So when this toxin binds to the endothelium, it's internalized. The alpha subunit then interferes with protein synthesis, and you get cell death, endothelial cell death, which causes thrombosis. Now, Jerry's going to talk about the epidemiology of this condition and treatment.
So this is a very important entity because there are epidemics virtually every summer. I mean, and this goes back, and you'll see, there'll be an epidemic this summer as well. So if you go back, one of the first big epidemics was many years ago. Preliminary report, foodborne outbreak of E. coli 0157H7 in hamburgers in the western United States. Now, I don't know how many of you are from the West Coast. I don't think Jack in the Box is in the East Coast at all, but it's certainly all over the West Coast. I mean, it's the equivalent of McDonald's or Wendy's on the West Coast. In any case, somebody at Jack in the Box found out if they cooked the hamburgers a little bit less, people liked them more and they bought more. So the next guy cooked them a little bit less. And then the next guy hardly cooked them at all. And what happened? They had a lot of E. coli with its toxin, and they got an epidemic of this hemolytic uremic syndrome. So that was the first big epidemic. But there has been an epidemic after one, after another, after another. So, Newsweek, can this meat kill you? Again, E. coli epidemics again and again. I was lecturing about thrombotic microangiopathies in Toronto. This is the headline of the newspaper I picked up, don't eat spinach from the United States because of hemolytic uremic syndrome. Again, a lot of people get diarrhea, but some of them not just get the diarrhea, but they get the full hemolytic uremic syndrome with the thrombotic microangiopathy. The petting zoos, again, trust me, when you have kids or, if your relatives have kids, you take them to a petting zoo, you've really got to be careful. This is actually from the Florida epidemic, and you can see this is 2005. I mean, 15 cases here, 3 of the kids died. So, I mean, this could, and a bunch of others ended up on dialysis. So, again, this can be really a disastrous condition. And this is taken from the front page of the New York Times, not in color there, but it was dumping Spanish cucumbers. There was an epidemic, again, summer epidemic, in Germany and France. And they were trying to figure out what was causing it, what was contaminated with E. coli. And they finally decided that it was the Spanish cucumbers that were contaminated with the E. coli that was spreading this epidemic. Except it wasn't the Spanish cucumbers, they were wrong. And this didn't help the Spanish economy anyway, I can imagine. So it turns out that they had over 3,000 cases here. Now these were 3,000 cases, But again, the number of deaths rose up. There were 908 cases of true hemolytic uremic. These were cases of Shiga toxin diarrhea. 908 cases, 34 deaths in there that day. It was a unique strain of E. coli that was much more potent. It was quinolone resistant. You had to take much more in terms of Cipro resistant here. And the unusual thing, it was mostly in adults, not kids, especially in females. Usually in kids, it's a higher incidence in males, and nobody really understands why that is. But this was much higher in females here, with a much higher incidence of hemolytic uremic syndrome. Well, the problem was that if you're in Germany or France and you eat a salad, you're getting the cucumbers from Spain, but you're getting the tomatoes from Greece. You're getting the peppers from someplace else. They're all coming from different countries. And they finally localized what it was. It was actually their sprouts, which was a contaminated group of sprouts. The seeds for these fenugreek sprouts, which is like alfalfa sprouts, were coming from Egypt. And they were contaminated with E. coli, spread all over Germany, etc. But again, it was a highly lethal epidemic. This just shows you the areas with highest involvement. Now here, if you look at this, you're looking at gastroenteritis in males. This is gastroenteritis in females. This is hemolytic uremic in the males. This is hemolytic uremic in the females. And again, it was adult females that were getting the problem. And people went through every which epidemiologic, trust me, the epidemiology in Germany is just as good as in the United States. They did everything to try to figure out why females were more predisposed. The answer was obvious. If you're in Hamburg and you're a 32-year-old female, you're ordering the salad. The guy is ordering the steak or the salmon. They're not eating the same thing. It's the females were eating many more salads, and that's why they were getting more during the epidemic. Here's the course, typically. You can see the platelet count plummets down here. The creatinine and the AKI, the acute injury, occurs right here at the same time here. The LDH, which is an enzyme released from red cells, goes up as you have your hemolysis. So you have a microangiopathic hemolytic anemia, you get thrombocytopenia as the platelet pugs occur there, and your creatinine goes up. Now, if you take all hemolytic uremic, especially the episodic kind that occurs in kids, some people think people who get antibiotics are more at risk, not less. Bloody diarrhea, fever, vomiting, leukocytosis, young kids, and for who does worse, females over males, even though the number of kids getting it is usually a little more male. The renal course in kids, 50% dialysis, 75% need transfusion, neurologic symptoms, there's mortality, and there's long-term renal dysfunction. So again, this thrombotic microangiopathy is very important. And this just shows you in a series what they found. They found that 3 to 18% had end-stage renal disease, needed dialysis here. They could predict, who was going to need dialysis. But the important thing, and the longer you were anuric, the worse you did. But regardless, the important thing is you can develop bad kidney disease from this thrombotic microangiopathy, and many people are left with a residual of it. Okay, case number 2. This is a 28-year-old male who has a history of hemolytic uremic syndrome, but he never had diarrhea. They cultured him for Shiga toxin. It was always negative. And this was at age 12. He progressed to end-stage renal disease dialysis slowly over a number of years. He got a renal transplant from his mother at 20. 3 months later, the transplant failed. His brother is also on dialysis, starting to sound like a familial disease. The biopsy report from his failed transplant says thrombotic microangiopathy. The patient's complement values are checked, and they're low, especially his C3 level. Now, I told you the common diseases that have you a low complement. We didn't talk about this with the thrombotic microangiopathy. This is a systemic disease, but in the future we probably will more. But he has a low C3 level. His father is offering him a kidney. Should he accept his father's kidney? How many people want him to take his father's kidney and get off dialysis? How many people, okay. How many people want him to die on dialysis? No. How many people don't want him to take his father's kidney? Okay. How many people want to find a way to treat him so he can take his father's kidney? Yes. Okay. So let's see what he had on his kidney biopsy.
So his biopsy, this is from a transplant, and basically the pathology is very similar to what you see in a native kidney with HUS. This is from his failed allograft. And it's showing here chronic TMA changes. If you look on the upper left, it looks almost like a membranoproliferative GN. You've got duplication of basement membranes, hypercellularity. But if you do immunofluorescence, there are no deposits here, so it's not an immune complex GN. The EM on the top right shows similar findings to what I showed earlier. Duplication of the basement membranes, 2 layers of GBM with this subendothelial fluff or flocculent material under the endothelial cells. So this is a chronic thrombotic microangiopathy picture consistent with his history of atypical hemolytic uremic syndrome. So again, in terms of terminology, we have HUS. The most common form is the diarrhea associated that we talked about first. That's D positive. This is D negative or diarrhea negative, also known as atypical. This accounts for about 10% of childhood HUS. So if you have any given child coming in with HUS, they're more likely to, much more likely to have the history of E. coli infection. But a subset like this patient did not. So these are non-E. coli related. And what causes this condition? Most of these are due to genetic abnormalities of complement regulation. So they either have a genetic knockout or an autoinhibitory antibody to factor H, factor I, or membrane cofactor P, all of which have a role in regulating complement activation on the surface of endothelial cells. Some of these cases, I said, are due to antibodies, so it's more like an autoimmune disease. They have normal genes, but they produce an autoantibody or an inhibitory autoantibody that has the same function and effect as if they had a genetic defect. In some of these patients, liver transplant has been attempted because factor H and factor I are produced by the liver. So the theory is if you give them a liver as well as a kidney, you're replacing the lost factor H. The outcomes of that have been very variable, and Jerry will talk about that maybe, but it's a very severe treatment and it doesn't always work. The important thing with this condition, to distinguish it from the diarrhea-positive HUS, there's a very high recurrence in the transplant, as you'd expect for a genetic disease. So giving him a kidney, whether it's from his father or anybody else, he's very likely to develop the same disease again, probably 90% likelihood of developing recurrence of HUS. So in this case, his father's kidney is probably normal. His father and mother are probably carriers. This is an autosomal recessive condition, so the parents, if you have only one gene knockout, your kidney will function fine. They don't get the TMA. So his kidney would actually be normal, but it's, in a way you could say it's a waste of a kidney. It's very likely to recur and with the same complications to develop graft failure. So the thrust of trying to manage this condition now is to try and find ways of treating it medically. And that's what Jerry's going to talk about in just the next slide. So just showing where these genes are mutated. If you have autoantibodies or genetic defects of factor H, factor I, or factor B, you can get gain-of-function mutations of C3, and then membrane cofactor P, MCP, that's the other big one. Any of these, if these are genetically mutated, you can develop abnormal complement C3 activase activity. And that leads to persistent complement activation, which results in endothelial injury and TMA. So now Jerry's going to talk about the management and the new drug that's available.
So this would be interesting academically if it weren't for the fact that we now have complement inhibitors, and they're just being developed, but one is already commercially available. And you can imagine how important it is splitting this off from the other disease. The Shiga toxin-positive diarrhea cases, you treat them with supportive care. They're trying to find ways to bind the Shiga toxin in the kid's stool and everything. But here, it's a totally different thing. In the past, they used to use plasma exchange. If you were missing one of those systems that break the complement system, the problem here is the alternate complement pathway is revved up and it keeps going on and on and on, especially on the endothelium. So if you're missing factor H, which is a break on the system, or you're missing factor I, if you restore it with plasma exchange, you would correct it, except you have to constantly give plasma exchange. If you have an antibody against these breaking systems, factor H, factor I, plasma exchange removes the antibody, you replace normal, and you correct it. But again, constantly you'd have to do it. Now we have humanized monoclonal antibodies. Eculizumab is the first. It blocks complement activation. Here you see
The alternate pathway goes not through immune complexes, but through C3 directly down to C5, hits the membrane attack complex that pokes holes in cells here, activates. This is an aflatoxin, brings in cells. This is where eculizumab blocks. It blocks that whole part of the system. So this just shows you, if you look here at the percentage of patients here with atypical hemolytic uremic syndrome at weeks 26 and at week 62, what percentage of patients were free of thrombotic microangiopathy here, by this definition here. But you can see the vast majority treated got better. If you look at hematologic normalization, that is, the platelet count came up to normal, the LDH there came back to normal, no hemolysis, you're talking about huge percentages. If you talk about the patients who were on dialysis, no patient required new dialysis here. Virtually everybody here did better in terms of this. Enough so that with a very small study, you're talking about 80-something patients, the FDA approved the drug for atypical hemolytic uremic. It's totally changed the disease. We would now treat this young guy with eculizumab. It would block that constant activation of his complement system here, and then we give him his father's transplant. The problem is you have to keep giving the eculizumab. It's a monoclonal antibody every 2 weeks, and it's the most expensive drug I know about. I mean, it is literally the most expensive medicine I know. Trust me, I know a lot about expensive medicines because the patients complain about it. So we do need alternatives to this. We need other blockers of the complement system, but this is a huge change that's taken place in just the last few years. You can see this New England Journal paper is from 2013. So atypical hemolytic uremic is due to persistent complement activation of the alternate pathway. It can be due to genetic defects or antibodies that block certain proteins. It responds very well to terminal complement activation by blocking C5. Okay, case 3. Now I just want to pause for a minute and say that key slide that Dr. Stokes put up before showing you TMA and the different things, 10 years ago, they were all lumped together. We knew the histology, we just didn't know the different causes. But as you're slowly starting to see, knowing the etiologies and the pathogenesis changes the treatment for every one of these. Now we have specific treatment just in the last decade based on the pathophysiology. So this is a 36-year-old, previously healthy, African-American female who develops fever and bruising. She goes to her primary care physician. Her CBC shows that her platelet count is way down at 15,000. Her hematocrit is 28%. She's anemic. She has a normal protime and activated partial thromboplastin time. Her blood smear shows a microangiopathic hemolytic anemia with those schistocytes in it. So right away, you know which category this person is in. This person is in the same group with hemolytic uremic, TTP, atypical hemolytic uremic. Over the next few days, her urine output declines. She develops sudden blindness, followed by a decrease in mental status. An assay for a certain metalloproteinase, ADAMTS13, shows marked reduction. It's less than 5% of this metalloproteinase, which is also known as von Willebrand cleaving protein. She's treated with daily plasmapheresis. We remove plasma and we give her back fresh frozen plasma. For 14 days, her mental status improves. She wakes up and everything. Her vision returns. Her LDH goes down, showing she's not breaking apart the red cells. Her platelet count comes up, and her renal function improves. Her diagnosis is TTP due to severe deficiency of ADAMTS13. So what would we find in her kidney? We might have found it in her brain and other organs as well, but we're doing a kidney biopsy.
So the pathology here is more chronic than what we saw in the previous two cases, a little bit more like the second case. We're seeing duplication again of basement membranes, a kind of an MPGN or mimic of an MPGN pattern on the left side with double contours. On the right side, you can see that some of these capillaries are blown out. This is what we call mesangiolisis. So it again reflects the presence of chronic endothelial injury. The endothelial cells lose their attachment to the mesangium, and you form these microaneurysms or fused capillaries. It's a feature of chronic TMA. In this case, you see a lot of arterial disease. And in this, on the left-hand side, you actually see some fresh vibrant thrombi in here. So there's actually the pink material is the, I don't know if this is working. The light pink material is the fibrin in the center of the lumen with some mixed red cells. On the right side, it's a more organized thrombus. You've got endothelial cell swelling, and that light blue material here is the what we call mucoid intimal hyperplasia. That's, again, the endothelial cells are on the center here. That's the small little lumen of the vessel. So it's narrowed by the presence of this proliferation of intima. And it's a sign that there's been injury or damage to this blood vessel. We see similar changes with malignant hypertension. So from a pathologic standpoint, the description is quite simple and generic. It's this chronic glomerular and arteriolar thrombotic microangiopathy, probably with some acute arterial thrombotic microangiopathy as well, because there are fibrin thrombi. But the overall diagnosis here is thrombotic thrombocytopenic purpura, or TTP. And that diagnosis is based on the lab test, the low von Willebrand factor protease levels. So as I mentioned earlier, there are two main clinical, or historically we talked about two main clinical syndromes of TMA. On the left, you had the HUS, where you had renal manifestations predominating. These are kids coming in with acute kidney failure. TTP, on the other hand, were patients with TMA who had more extrarenal manifestations, like CNS manifestations or skin manifestations, without so much kidney involvement. But as this figure illustrates, there is a lot of overlap. So we weren't able to tell, really, just looking at pathology, whether a person had an HUS or a TTP. What changed, really, was the discovery of what causes TTP, and that was only in the last 15 or, I suppose, or 20 years. So the new classification of thrombotic microangiopathies, the updated, we basically have two main categories. There's HUS on the left, TTP on the right. HUS, two subgroups. The classic type is due to the shigatoxin-producing E. coli, and that's the majority of cases. The less common is the atypical HUS due to dysregulation of the alternative complement pathway, and that's either due to genetic or autoimmune disease. And then there's a subgroup of smaller categories of atypical HUS, various drugs, particularly chemotherapeutic drugs, VEGF inhibitors, severe hypertension. All of these can also cause an atypical HUS, a diarrhea-negative HUS, but they're all pretty uncommon. On the right side, TTP, this is a disease that's due to severe ADAMS13 deficiency. And ADAMS13 is a molecule that we all produce in our body. If the levels are reduced to less than 5% of the normal population, that's considered severe. And that's the key pathologic finding, or the key lab finding in this condition. This was first discovered in rare families that had a genetic deficiency of ADAMS13. Those are very, very uncommon. We see more and more cases now that are due to autoantibodies. So in fact, the autoantibodies are the most common cause of TTP. So these, again, these are people who develop an autoimmune type disease, a lupus-like disease. They produce an antibody that interferes with or blocks the ADAMS13. I think, Jerry, do you want to just talk about the clinical and then pathogens?
Okay, so again, this can be familial or acquired. You can have a single episode or relapsing disease here that it can occur in almost any age, but females, peak or younger people here. And again, CNS renal manifestations, you can get all of these. I don't know why we wrote renal involvement is rare. For us, renal involvement is common, actually. But, again, if you take hematologists, they see a lot of people who don't have major renal involvement. But I'm taking that out. I don't know how we got that in there. Okay, ADAMTS13, what is it? It's a disintegrin and metalloprotease with thrombospondent-like domains. There is ADAMTS13. Okay. It's also known as von Willebrand factor cleaving protease. Okay? So normally this protease degrades multimers of von Willebrand factor. If you have a deficiency, you get all these circulating large factors, von Willebrand factor proteins that lead to coagulation in the circulation. So here you can see what happens here in terms of this. If you have the large von Willebrand factor multimers, which we all do, if you had ADAMTS13 normally, your normal protease, you break it apart, and what happens? you get small multiples, and it's normal. If you have a deficiency of this, you get coagulation in the vessels, and exactly that's what's happening here as well. So again, if you're missing this protease, you could be missing it because you have a genetic deficiency, you could be missing it because you have an antibody against it. This just shows you if you take levels of ADAMTS13, these are normals, these are people who are severely deficient. Now, these are moderately deficient here, but regardless, if you take people who have 30, 40% of their ADAMTS13, they don't get disease. If they have 5% or less, they do. So if you take, the bottom line of this is, looking at 127 cases in 4 years, everybody had severe ADAMTS13 if they had true TTP. And that's how the definition was made, by severe deficiency. The treatment has been plasma exchange. You remove any of the multimers of von Willebrand's factor. If you're missing the ADAMTS13, you're replacing it, okay? If you have an antibody against it, you're removing it. So the removal of fluid takes away the antibodies, if you have that, and the factor, the large multimers. The replacement gives you the ADAMTS13. It's a perfect treatment for it. The question is, some people relapse multiple times, and now there are other ways to treat it. If you have an antibody, you can use new drugs that block antibody production, such as rituximab, that will work. There are many ways to treat it, but that's still the mainstay, is still plasma exchange. Okay, our next case is a 27-year-old stock analyst who's had 3 spontaneous abortions, and she has Raynaud's phenomena. Her hands turn white or blue, or both, when she goes out in the cold. She has had a deep vein thrombophlebitis of the right calf after an auto trip. She has arthralgias, fevers, and malaise. Her blood pressure is elevated. She has a malar flush, a systolic ejection murmur. She has swollen metacarpophalangeal and proximal interphalangeal joints. She has livedo reticularis of the legs and arms. Anybody know what that is? You're going to know in a second. I'll show you a picture. And then she has edema. She's slightly leukopenic, anemic, thrombocytopenic here. She has red cells and red cell casts in her urine. She has a glomerular disease, which could be due to thrombosis here. BUN is 43, creatinine 2.6. She has AKI, the creatinine's elevated. She has proteinuria. Her ANA is strongly positive. And you say, wait a minute, this person has lupus. Her anti-DNA antibody is totally normal. Her complement is only borderline. And she has a false positive VDRL. She has antiphospholipid antibodies. If you look at her hands, she has this dilated network. This is livedo reticularis. This is a severe case of livedo reticularis. You can see it's almost necrosing here in terms of this. So a renal biopsy is performed. Let's see what's going on in her kidneys.
So this condition, antiphospholipid antibody nephropathy, is characterized by predominantly chronic changes in the kidney. So these patients get recurrent thromboses in the vessels, not just in the glomerular capillaries and in the arterioles, but actually in the large vessels as well, like the renal artery and maybe renal vein. And that causes ischemic changes throughout the kidney. So they get characteristically cortical atrophy, which is scarring of the cortex. And it's patchy or focal. And that reflects the vascular distribution. So if you take out a kidney and you've got wedge-shaped areas of scarring, that's usually a clue that you're dealing with a vascular disease. So down here on the left is the capsule, that's the surface of the kidney. Under the capsule you've got this scarring, you've got inflammatory cells in the atrophic tubules. The glomerulus is shrunken, it's ischemic, just retracted like that. Here are some sclerotic glomeruli adjacent to it. And then other glomeruli elsewhere showed ongoing thrombus formation. So these glomerular capillaries are filled with red cells and fibrin thrombi, and the arteriole up here on the left also shows fibrin thrombi. So there's a mixture here of both acute and chronic changes in her kidney. This is showing the more chronic features, similar to some that I've showed you earlier, GBM duplication, glomerular basement membrane duplication. There's also some loosening, or instead of having a solid pink material that you see with sclerosis, it has a net-like or reticulated appearance. This is what happens to these thrombi when they organize. So you get a reticular or mesangiolitic appearance. Here's an arteriole adjacent to that's the glomerulus here. The arteriole here is filled up with fibrin thrombi, which stain red here with the trichrome stain. So these little filamentous or fibrils are fibrin. Here's another vessel with fibrin thrombi on the right, and this, probably the same vessel, is filled with red cells, so there's congestion with red cells. This is the more organized phase of TMA in the vessels. The fibrin thrombi are gone at this point, but you see the mucoid intimal hyperplasia. So the intima is reacting, you get a proliferation of cells trying to remove these thrombi and recanalize. And indeed, the last stage, when you've got a recanalized thrombus, this is actually an arteriole with multiple vascular channels. This was a thrombus probably a couple of months before. It's recanalized. We also use the term glomeruloid bodies for this. They're actually arterioles or arterioles that look like glomeruli because they have all these vascular spaces. And this is a feature of chronic thrombosis. So our renal biopsy findings: acute and chronic thrombotic microangiopathy. The presence of patchy subcapsular cortical atrophy in this case is very suggestive of large vessel involvement as well, which is a clue to this condition. And all of these findings are characteristic of antiphospholipid antibody nephropathy. So now, Jerry, do you want to talk about the antiphospholipid?
So, antiphospholipid antibodies are a family of antibodies. They can be of different immunoglobulin subtypes against negatively charged phospholipids. They include what was known as the lupus anticoagulant. These are antibodies that prolong lipid-dependent coagulation, so they interfere here with the protein thrombin activator here, and that's why it looks like in vitro that it's an anticoagulant here. You have a long APTT, but actually they clot. These people clot. You can have anticardiolipin antibodies, bind to cardiolipin. Again, the major things, all of these lead to coagulation. 3 underlying conditions. Lupus, very common. Lupus-like. Our patient is certainly lupus-like here. She has a lot of manifestations, but her anti-DNA is negative, the complement is normal. And then there are people that get 45 or 50-year-old guy, very unlikely to have lupus, and they have antiphospholipid antibodies. This is what the syndrome is. Recurrent arterial and venous thrombosis because of placental thrombosis, recurrent miscarriages and abortions. Libido-reticularis, that's a tip-off. If you see somebody with that, always think of this. CNS disease due to coagulation, pulmonary hypertension due to coagulation, chronic kidney disease due to what Barry just showed you, hypertension related to the kidney disease, and rarely you can get clotting in multiple organs at one time. This is the classic clinical picture of it. Now I'm going to skip over a couple of slides here because this just shows you what a series at Columbia had, but again, it's the same as those major findings. The details aren't important. So our last case is a 70-year-old white male with long-standing hypertension, mild chronic kidney disease. His blood pressure becomes increasingly difficult to manage. He gets a renal angiogram. And on this, it's actually an MR angiogram. He has, here's one kidney over here, here's the aorta, here's the renal artery. Look at the other renal artery. Tight renal artery stenosis in that kidney going there to his right kidney. And if we dissected him, we would find tight renal arteries. This is a different patient. Tight renal artery stenosis. So I think, Barry, you do these. I'm showing the pathology. Maybe, I don't know.
So this is what happens. This is why his hypertension got worse. Because you've got stenosis to this right kidney in this case, you've got reduced perfusion. Ischemia leads to increased production of renin and angiotensin. That causes intrarenal hemodynamic changes, including sodium retention. So his blood pressure goes up. So this is one of the causes, secondary renovascular hypertension. And it's something to consider, especially in an older person who's got atherosclerosis or hypertension, if their blood pressure gets worse. In this case, he was treated by placing a stent to bypass the block. His blood pressure got better, but then he subsequently, a few days later, developed acute kidney failure with a rash and eosinophilia. And a renal biopsy was performed. So what the biopsy, I'm just going to skip, I'll come to the biopsy in a second, but this is what his kidney would look like, again, if we did a gross exam, if you looked into his body. The kidneys in hypertension are usually shrunken and small and have a granular surface. The cortex is thinned. It's normally about 1 centimeter in thickness. Here it's about 0.5 centimeter, and that's due to chronic ischemia because of hypertension. And if you look under the microscope, what you see with hypertension is arterial disease. So you get thickening or arteriolar hyalinosis in the vessels, secondary ischemic changes in the glomeruli, wrinkling of the basement membrane, some fibrosis and inflammation. And in a case of severe hypertension, you can actually see again fibrin thrombi or thrombotic microangiopathy. But in this case, what he had, the reason for his acute kidney failure was not thrombos, not fibrin thrombus, but cholesterol thrombi or cholesterol embolus. So because he had the stent procedure and he had pre-existing atherosclerosis in his aorta, some of these atherosclerotic plaques dislodged and traveled into his kidney. These, even though they look empty, these are actually solid. They're cholesterol crystals. So they're blocking the perfusion, and you get acute kidney failure because of cholesterol embolization. This is another example showing a clearer picture. There's the glomerulus. This is a blood vessel. These needle-shaped or crystal-shaped inclusions represent cholesterol emboli. So this is a common, relatively common complication in older people. The risk factors, they usually have a history of an invasive arterial procedure, either a stent placement or an arteriography or coronary artery bypass grafting. But it can occur spontaneously as well. So if they have very severe atherosclerosis, these plaques can dislodge spontaneously. Clinically, our case illustrated the typical presentation, acute kidney failure. They may have a rash and eosinophilia. The rash is probably because they have these cholesterol emboli in the skin. So they don't just go to the kidney, the showers of emboli go all over the body. You can get involvement of the GI tract. They can present with mesenteric ischemia. They can present with bowel infarcts. And if the blood vessel that's occluded is big enough, you can get infarction of the kidney. So you can get chronic kidney disease as a result of this. They don't usually get better. So we have two diagnoses here. The acute kidney injury is due to the renal atherembolic disease. The chronic kidney failure is due to his underlying hypertension or hypertensive nephrosclerosis. So this is our last slide. So Jerry, I don't know if you want to just talk about this. So this is just to summarize, just to be aware, for thrombotic microangiopathy, it's a pathologic description. It's a pattern of disease. It's got a number of different causes. The important ones to be aware of are the E. coli Shiga toxin-like. That's the most common. That's the classic HUS or diarrhea HUS. The more important group from clinical point of view probably is the complement dysregulation group, because we now have a treatment for that. That's the atypical HUS, and these respond very well to this new drug that inhibits the complement pathway. TTP is due to Adams 13 deficiency or von Willebrand protease deficiency. Most of those cases are due to autoantibodies. Some of them are genetic. And then finally, antiphospholipid antibody syndrome, again an autoimmune disease that causes thrombi in multiple organs, not just the kidney, often presents with arterial thrombosis, venous thrombosis, recurrent abortions. And then finally, in older people, atherosclerosis. Be aware it can cause chronic kidney disease just due to hypertension and reduced perfusion. And it can also cause acute kidney injury if you've got sloughing or embolus of these cholesterol emboli from the artery into the kidney. So I think that's our last slide. If you have any questions, I'm happy to try and answer.
So I think I was too long. In a week, I can revise some. I think this is I mean, like, what I'm going to do is maybe I'll sit down with you. I'll tell you the now has been I can shorten down the German epidemic to like 2 slides or 3 slides because it's difficult to but I mean, whatever we see does. Anyway, that was the barrier. You're good on your part. I have to work on
I think Betty just sent an email. I think she just emailed. Did you get the...
Yeah, I forgot to
Good. Sorry about that.
Yeah, I think so. Yeah, they got them. Yeah, thank you. I was in the middle of emailing it to our whole class list, and then Dr. Garrett was able to get Betty to post it also. So I think we got 2 events to cover. Thank you.
But it's clear that we have plenty of time. We can together. I do think everybody should slow
No! Stop! They turned off the light.